Let's look at four selected joints in the body. These four are going to be the shoulder, the elbow, the hip, and the knee. Those four joints are typically joints that have the most movements, and they are used quite a bit in athletics and sports and exercising, and therefore they are overused sometimes, and a lot of stress is placed on these joints, and therefore you're going to see a lot of injuries to the joint and structures that might protect and support those joints. So we're going to start with the shoulder joint. Specifically, it is known as the glenohumeral joint because it is a joint between the glenoid cavity of the scapula and the head of the humerus. And that's typically what we call our shoulder joint. There's actually another joint located in the shoulder area. That joint is between the clavicle and the acromion. So that is known as the acromioclavicular joint. So you actually have the acromioclavicular joint and the glenohumeral joint all in this shoulder area. But typically when we say shoulder, we're referring to the glenohumeral joint. So let's look at a few things. One being a bursa. So we haven't talked about a bursa, but a bursa is described as a fluid-filled sac used to cushion certain areas surrounding a synovial joint. So this structure is a little sac, and the fluid inside is much like synovial fluid. But what this fluid-filled bursa is doing here is it's cushioning between rigid structures. We're going to look at another picture to help us understand why, but you'll notice that there's a tendon coming from this bicep muscle. And that tendon is going to be situated in between two bony structures, specifically the humerus and that acromion of the scapula. And this arm, this shoulder joint moves dramatically. You can imagine you can lift your arm up, it might squeeze together the humerus and the acromion. So you need to have a cushion there to protect that tendon from being damaged. So you find a number of these fluid-filled cushions around joints that have a lot of mobility. The shoulder joint has this subacromial bursa because it's underneath the acromion. You'll notice here's another one called the subscapular bursa. A number of bursa in the shoulder. If there's inflammation to a bursa, we call that bursitis. That is a fairly common complaint with shoulder joints, elbow joints, knee joints, is this inflammation that can occur with the bursa. Notice that there is a coracohumeral ligament. What I'm just trying to do here is point out different names to some of these ligaments. And you'll notice that they're just typically named after what two bony structures that ligament attaches to. This one attaches the coracoid process in the humerus. There's another one, the glenohumeral ligament, is between the humerus and the glenoid cavity. This is a frontal section through the shoulder joint. And this section, this view allows us to see a number of different things. Again, we can see that there is a bursa strategically located in between the acromion and the humerus. And that, again, protects this tendon coming up from the biceps brachii muscle. It also protects the tendon of this muscle known as the supraspinatus muscle. So that bursa helps cushion that area. You'll also notice that we have the cavity, the synovial cavity filled with synovial fluid. We have the head of the humerus covered with articular cartilage, the glenoid cavity covered with articular cartilage. Then notice there's a couple structures shown here known as a labrum. The glenoid labrum, labrum meaning lips. So these are made of fibrocartilage, so they're fibrocartilaginous lips, which if you look, what they do is they help deepen this socket. So it helps deepen the socket in order to have a better fit for the humerus. And that is another complaint often seen with shoulder joints, is tearing of the labrum. So a labrum is a piece of fibrocartilage that deepens the sockets. You have a labrum in your shoulder joint, the glenoid labrum. You also have them in your hip joint, inside the acetabulum. Moving down to the elbow joint, there's also two joints at your elbow. There's the joint between your humerus and your ulna. That joint is your typical hinge. The ulna, if you recall, can only flex and extend. There's also a pivot joint. The pivot joint is located over here, and it is formed between the radius and the ulna. The pivot joint is formed using this annular ligament, which forms a ring, and then the radius can rotate or spin within that ring. So there's actually a couple different joints, and therefore your elbow area can flex and extend as well as cause pronation and supination at the palm or hand. Notice protecting the skin of the elbow is an olecranon bursa. So this is an example of where we have a fluid-filled cushion, not necessarily protecting a tendon, but it's protecting the skin that overlies the olecranon. Because you've probably bumped your elbow into many things. And in order to protect that skin from being damaged by the olecranon, there's a bursa located there. Bursitis would inflame this sac, and you could actually see an enlarged olecranon bursa in someone with bursitis. So we notice the annular ligament forming the pivot joint. We notice the bursa. You'll also notice that there are some collateral ligaments that are found on each side of the elbow. The collateral ligaments, shown here being the ulnar collateral ligament on the ulna side. Over here we see that there are radial collateral ligament on the radius side. Those help stabilize that elbow joint. If you've heard about Tommy John surgery, that is a specific surgical procedure in quite often baseball pitchers where there is damage to the ulnar collateral ligament. Hip joint, ball and socket between the femur, the head of the femur, and the acetabulum. Here we're just pointing out again some different ligaments named after what the ligament attaches to. There is a iliofemoral ligament because it goes between the ilium and the femur. So that's this guy here. Remember, the ilium is this upper part of the hip bone. There's a pubofemoral ligament because it goes between the pubis, which is this anterior region, and the femur. There's also an ischiofemoral ligament, which is seen posteriorly. Now we go to the knee joint. And if you're going to know any joint in the body, the knee joint would be the best one. It's the more complicated joint in the body in that it's got bursa. It has two menisci or meniscus. It has a lot of different ligaments that we've heard of, like ACLs and MCLs. It's damaged very often. There's a lot of stress. There's more weight bearing down on the knee joint than any other joint. So this would be the one to know very well. First, we have to look at the bones. We have the distal end of the femur. So this knee is in the flexed position. It is bent at roughly a 90-degree angle. The distal end of the femur has the two large condyles, the medial condyle and the lateral condyle. Notice we can tell that this is the lateral side because there's the fibula. The fibula is going to be positioned laterally. Those condyles are going to articulate with the tibial condyles. In between the condyles, there are two menisci, the lateral meniscus and the medial meniscus, which are fibrocartilaginous cushions between these two bones. You'll notice that the fibula is not really participating in the joint. That's why it's a non-weight-bearing bone that does more at the ankle, really. It stabilizes at the ankle area. But there is a ligament that attaches to it and goes up to the femur. That one's known as the fibular collateral ligament. So just like the elbow, you have collateral ligaments on each side. These are often called extracapsular ligaments because they're found outside of the synovial capsule, whereas the cruciate ligaments are found inside the synovial capsule. But let's look at the extracapsular ligaments. On the lateral side, we have the fibular collateral ligament. It's also commonly called the lateral collateral ligament because it is on the lateral side. On the medial side, we have the tibial collateral ligament, often referred to as the medial collateral ligament, hence the MCL you often hear about. Then you have the cruciate ligaments, and the word cruciate refers to crucifix, which is a cross. So these two ligaments cross inside the articular capsule. The one crossing in the front is called the anterior cruciate ligament, or ACL. The one crossing in the back is the posterior cruciate ligament, or PCL. So those are the four major ligaments in the knee. There's actually a fifth called the transverse ligament of the knee. That one holds the two menisci together. So it's a transversely positioned ligament between lateral meniscus and medial meniscus. This is a superior view looking down at the menisci as well as the tibia and the fibula. In essence, we've cut right through the joint, removed the femur, and we're looking downward. Again, it helps you see that the menisci are going to add a little bit of cushioning as well as allow these two bones to fit better together. So the purpose of the menisci is to distribute the force evenly across the tibia. You do not want the force from the femur to be forced right in a small area on the tibia. You want that force to be distributed throughout the tibia. So medial meniscus, lateral meniscus, there's that transverse ligament holding those two together. And then we've cut through the other four ligaments. The fibular collateral ligament, notice it is coming off the fibula. The tibial collateral ligament, also known as the medial collateral ligament. And then the two cruciate ligaments, the posterior cruciate and the anterior cruciate ligaments. There is yet another ligament that we see here called the patellar ligament. That's the one that allows the patella to attach to the tibial tuberosity. It is actually an extension of a tendon known as the quadriceps femoris tendon. Here's a sagittal view of the knee joint. What this adds to our knowledge is the fact that there's bursa, prepatellar, infrapatellar, suprapatellar, all strategically located, protecting either soft tendon like the patellar ligament or skin or a tendon here, the quadriceps femoris tendon. So notice that the quadriceps femoris tendon goes from quadriceps to patella, but then extends and becomes the patellar ligament. So it's all kind of the same tissue, but here it would be a tendon because it's muscle to bone. Here it's a ligament, bone to bone. You also notice there's a lot of fat in the knee joint, and that fat kind of helps cushion around areas as well. We notice that the menisci are going to help distribute that force. You don't want the force just right here. That would damage both bones. You want to spread that force out evenly. Finally, we've heard of hip replacements and knee replacements, and we have a company in Naples called Arthrex, who primarily deals with these components, but also other medical equipment. But you'll notice these are kind of neat images where in order to replace that dysfunctional hip joint because of probably cartilage damage and bone damage, they remove the head of the femur, they reshape the acetabulum, get all that cartilage out of there, and then they put an artificial cup acetabulum in the hip, and they have an artificial femoral head which goes in the femur. And there's your artificial hip. And then a knee replacement is very similar in that you remove all the damaged cartilage, and you have three components. You have a femoral component, which replaces the femoral condyles. You have a tibial component, which replaces the tibial condyles. And quite often you have a patellar component, which replaces the patellar, either the whole patella or just the posterior surface of the patella. So that's the end of the joint lecture. Hopefully you've understood what to do, which is know your different classifications of joints, structural, functional classifications. And then you'll notice most of our time is spent studying those synovial joints, what kind of joint is found in each area, what kind of motion does that joint occur, and are there any other special structures found in that joint, whether it's a bursa, a meniscus, or a labrum.